Hi, we're second-year master's students in Carroll University's Clinical Exercise Physiology program. The researchers that have conducted this study are Gabriela Zamish, Anina Lee, Madeline McVeigh, Elizabeth Tredo, and Justin Mathai. Supported alongside our professors, Dr. Jessica Brown and Dr. Daniel Shackelford. We appreciate you taking the time and listening to our research. The title of our research is The Shackelford Treadmill Protocol and its predictive equations accurately assesses VO2max in multiple chronic diseases. VO2max refers to the maximal volume of oxygen that the body can utilize during maximal exercise, serving as a key indicator of how effectively the body delivers and uses oxygen in the muscles during high-intensity physical activity. It reflects the integrative efficiency of the cardiovascular, respiratory, and muscular systems. This measurement is considered one of the most reliable indicators of overall cardiovascular fitness and aerobic endurance. VO2max is typically measured through a graded exercise test on a treadmill or a cycle ergometer, where intensity is gradually increased in a controlled manner until the participant reaches a volitional exhaustion, ideally from cardiovascular rather than muscular fatigue. A low VO2max is a strong predictor of cardiovascular disease risk, as it highlights limitations in the body's ability to circulate oxygen-rich blood to vital organs and working muscles. Moreover, a reduced VO2max has been associated with impaired insulin sensitivity, elevating the risk of metabolic diseases such as type 2 diabetes. In populations with chronic diseases, including heart disease, diabetes, and cancer, common side effects include increased fatigue, shortness of breath, reduced musculoskeletal function, decreased range of motion, and chronic pain. These symptoms are often exacerbated by prolonged sedentary behavior, poor dietary habits, physical deconditioning, joint stiffness, and systemic inflammation.
Cancer survivors often experience profound fatigue, muscle weakness, and cachexia, or severe muscle wasting, all of which significantly limit their physical capacity and exercise tolerance. Traditional VO2max protocols typically rely on large increases in speed and incline, which can be too aggressive and unsafe for special populations, especially those with compromised functional capacity or pre-existing conditions. These intense protocols often result in early muscular fatigue or injury risk, making it difficult to obtain accurate cardiovascular performance data. To address these limitations, the Shackelford Protocol was developed. The Shackelford Protocol is specifically designed to gradually increase speed and incline with more modest intensity increments and shorter stage durations, making it safer and more accessible for individuals with chronic conditions. Despite its lower intensity, the Shackelford Protocol remains effective in eliciting VO2 peak, as the shorter stages allow participants to reach a true point of cardiovascular fatigue, without being limited by musculoskeletal discomfort or early termination. This ensures more accurate data collection while reducing physical strain and injury risk. Given that many chronic disease populations exhibit similar physiological challenges to cancer survivors, including fatigue, musculoskeletal deficiencies, and systemic weakness, it is critical to validate the Shackelford Protocol across various clinical groups. Doing so could support broader implementation of safer, more inclusive fitness assessments in clinical and rehabilitative settings, ultimately improving health outcomes through more personalized and attainable exercise prescriptions.
Figure 1 shows the Shackelford Treadmill Protocol used to conduct this study. This is a multi-stage treadmill protocol in which each stage is 1 minute long, and there's either an increase in speed, grade, or both while progressing through the protocol. This protocol can be used for both max and submaximal cardiovascular treadmill tests. Figure 2 displays common side effects shared between chronic disease populations including cardiovascular, neurological, metabolic, and renal diseases. These diseases can lead to an increase in cardiovascular side effects, increased shortness of breath, increased fatigue, increased muscle pain, and a decrease in range of motion within the joints. Our purpose was to examine the validity of the Shackelford Protocol and its predictive VO2max equations in cardiopulmonary, neurological, metabolic, and renal disease subjects. The primary objective of this study was to evaluate the validity of the Shackelford Protocol, including its predictive equations for estimating maximal oxygen uptake, VO2max, across a diverse group of individuals diagnosed with chronic cardiopulmonary, neurological, metabolic, and renal conditions. VO2max is a well-established marker of cardiorespiratory fitness and an important prognostic indicator in various chronic diseases. Given the clinical importance of accurately assessing VO2max, especially in populations with altered physiological responses to exercise, it is critical to determine whether emerging testing protocols such as the Shackelford Protocol can reliably estimate this parameter.
Table 1 gives a breakdown of our participant demographics. We had 46 participants complete our study. 20 of those were males and 26 were females. Of the 46, we had 12 cardiopulmonary, 8 neurological, 17 metabolic, and 9 renal participants. Average age, height, weight, and actual and predicted VO2max are also listed for all chronic disease groups. Each of these participants underwent a VO2max test using the Shackelford Protocol. A metabolic cart with gas analysis was used to assess true VO2max. Following this, we used the ACSM walking or running equations to estimate their VO2max using the same treadmill test results. A Kruskal-Wallis test was conducted to compare differences between all chronic disease groups, and a Wilcoxon-signed rank test determined differences within each chronic disease group. Each of our 46 subjects achieved at least one VO2max criterion when conducting the Shackelford Protocol treadmill test. For all subjects, there was no significant difference in VO2max when comparing estimated VO2max, which was calculated using the ACSM walking and running equation, versus their actual VO2max measured by gas analysis. Additionally, there were no significant differences within or between each group for estimated versus actual VO2max. Figure 3 shows the correlation between actual and estimated VO2max in all chronic disease subjects combined. The R-squared value is 0.7565, which indicates a strong positive correlation between measured and estimated VO2max. Figure 4 breaks apart each individual chronic disease to see the correlation between actual and estimated VO2max. Cardiopulmonary disease displayed an R-squared value of 0.86, renal disease displayed an R-squared value of 0.92, metabolic disease displayed an R-squared value of 0.76, and neurological disease displayed an R-squared value of 0.74. These all indicate a strong positive correlation between estimated and actual VO2max. Based on our data, renal disease showed the strongest correlation between estimated and actual VO2max.
The Shackelford Protocol elicited true VO2max in all participants and has been validated to predict VO2max in chronic disease populations using estimation equations. The rationale for the use of the Shackelford Protocol compared to other protocols for chronic disease populations includes increased mitochondrial dysfunction, muscular side effects, and inefficient oxygen extraction seen in these populations, which makes the gradual intensity of the Shackelford Protocol cater towards those side effects and allows individuals to sustain exertion levels to garner accurate results. That way, tests do not end prematurely due to muscular fatigue rather than cardiovascular fatigue, which is the goal of a VO2max test. This protocol has more merit in comparison to standardized treadmill protocols in clinical settings, such as the Bruce protocol, in that the Bruce requires a greater reliance on anaerobic metabolism, which leads to an increase in metabolic byproduct accumulation and an increase in premature test termination as a result. In addition, we also found that the estimation equations for the Shackelford Protocol are also accurate. This means that the use of the metabolic cart to assess VO2 max may not be necessary, since the prediction equations using the results of the treadmill tests leads to accurate VO2 max results. The use of the metabolic cart can be expensive, take well-trained staff, and exacerbate side effects seen in chronic disease populations, so if we could accurately assess VO2 max without it, that would be beneficial in creating precise exercise prescriptions. All in all, not only does the Shackelford Protocol validate cancer populations, but also chronic disease populations, which can allow for more accurate mortality risk predictions and improvement in exercise prescriptions.